I'm super excited to be here today, and thank you for joining in this afternoon to learn about CAR T therapy for autoimmune disease. I think what's going to be easiest, just because as I'm sharing my screen, it's hard for me to keep up in the chat. I have probably about 30-ish minutes of lecture slides, and then we'll have plenty of time afterwards for questions and hopefully some interactive conversation. And we can kind of discuss cases or discuss any clinical trials or any thoughts on CAR T, as well as experience with CAR T that anyone has. So with that, I'm going to jump into the talk. So again, CAR T for autoimmune disease, that's chimeric antigen receptor T cell therapy. I think it's important. It's just starting out here with my disclosures. Since I'm going to be talking about CAR T, I think it's pertinent that everyone realizes I do have involvement on the research side with that. So I am PI on the KYSA-8 study, which is a phase 2 CAR T trial in stiff person syndrome. I'm also PI on the Target Next CAR T, which is sponsored by BMS. And these are my other general disclosures, again, pertinent to this talk. I do have consulting fees from Kyverna. All right, so just to set the lay of the land here a bit, in this talk, we're going to talk about CAR T therapy for autoimmune neurologic disease. As many people here are aware, there's no FDA-approved therapies outside of NMO, MS and myasthenia gravis for immunotherapies. We do have 2 clinical trials undergoing that many may be aware for NMDA receptor encephalitis, as well as one for LGI1 autoimmune encephalitis, looking at monoclonal antibodies that either directly target B cells, so inebilizumab, or impact the B cell pathway, such as satralizumab. But many times we use these monoclonal antibodies that target those B cells, and we believe that these are effective. Again, yet we don't have all the data for many of these diseases. However, there's still limitations with these monoclonal antibodies. Again, we use these off-label with the exception of NMO, MS, and myasthenia. But regardless, even the approved drugs for those indications have chronic side effects. And for MS in particular, we don't see halting of progression. So I think even in autoimmune neurologic conditions that we have well-established drugs, this is still an interesting field to explore. So B-cell targeted CAR T is being investigated right now for many different autoimmune conditions, even outside of neurology. It is something that was primarily used in oncology, which we're going to get into in a bit. But now moving into the rheumatologic space, autoimmune space, and now neurology space. Beyond CAR T, there's also other approaches, CAR T with 2 A's, being another potential therapy that we'll talk about in this talk as well. And that's targeting disease-specific B cells while leaving healthy B cells intact. So looking at B cells, just taking a step back, and I know this is going to be a lot of review for some of the folks here, but B cells have a central role in autoimmune disorders. And this is the whole point of why we're thinking about CAR T, because we're really trying to target those B cells. And here on the left, you can see the normal B cell functions, and on the right side of the screen, you can see the role that they play in autoimmunity. So production of antibodies, presentation of antigens, and when you have those antigens that are towards self, you have this autoreactivity that you can see with T cells being activated. You can get the release of pro-inflammatory cytokines, B regulatory cells that can be altered in autoimmune disease. When we're talking about CAR T against CD19, I just want to remind everyone here what that looks like in the B cell lineage. There's a broad expression of CD19 within the B cell population, much broader than we see with CD20 expression. So even hitting some of those plasma cells all the way on the right here. So what is CAR T? CAR T is a type of immune therapy treatment using one's own modified T cells. Basically, a synthetic receptor is genetically modified into the T cell to regulate the lysis of its target. And in this case, we're talking about CD19 B cells. CAR T cells are effective against hematologic malignancies. They have known side effects, which we're going to get into, including cytokine release syndrome, neurotoxicity. But this is an exciting type of immune therapy that is really starting to extend beyond cancer indications into these autoimmune diseases. And I know this is a little cartoon-like, but it's my son actually loves it. He thinks he's a big CAR T guy. But you can think about it this way to conceptualize what this looks like. The T cells from the patient are taken to the lab. There's a retroviral vector that's given to the T cell, and it basically changes those chimeric antigen receptors are then placed on the outside of that CAR T so it knows its target to hit. And again, this is using a patient's own immune cells to do this. So this CAR T cell is then with that target, that flag on the outside of the CAR T, when it's given back to a patient, it basically removes their B cells, including unhealthy B cells that are driving the inflammation and autoimmune disease using that CD19 target. Now, the downside of this, it doesn't tell you what B cell, it's just every B cell with a CD19 that it's wiping out. So healthy plus unhealthy. Again, we know this method works in oncology. This slide here summarizes the indication in multiple types of lymphoma and multiple myeloma. That CAR T treatment is FDA approved and being used for those indications. We also know from the oncology world that based on this, these studies with these CARs, there are serious side effects that we can see. But the experiencing oncology has taught us how to improve upon these side effects and how to monitor these side effects and intervene early. So here from this figure from the publication here at the bottom, I just want to highlight the two most feared complications when we think about CAR T therapy. It's really the cytokine release syndrome, which most commonly happens very acutely within the first 10-ish days, which is why patients are hospitalized during this time for monitoring, as well as we can see neurotoxicity. And all of us here on this call, if you're neurologists, of course, this is one that has us concerned. We know with cytokine release syndrome, treating aggressively early using steroids, IL-6 blockade can be extremely helpful and minimize getting into severe CRS or grade 3 CRS. With neurotoxicity, we have ways of monitoring this. Again, patients are in the hospital being monitored closely with cognitive testings helping to aid in quick diagnosis and monitoring. So it's relatively recently that this is being explored for autoimmune disease, like I said. This is a perfect example, this publication, which was just of February of this year, summarizing a case series of 15 patients who received CAR-T for various rheumatologic disease. And this included 8 severe lupus patients, 3 inflammatory myositis, and 2 systemic sclerosis. A treatment for all of these patients here included a single dose of CD19 targeted CAR-T, followed after receiving lymphodepletion with cyclophosphamide and fludarabine. The median follow-up was 112 days. Immune therapy was basically stopped in all of these patients after CAR-T, and the side effect profile looked fairly favorable, including just one grade 1 cytokine release syndrome for 10 patients, and just one with grade 2. There was one patient that did have neurotoxicity. Another publication here on this slide shows long-term follow-up, and when I say long-term follow-up, I'm talking 15 months, done in 5 patients with severe SLE. These patients, they used a severity scale for lupus that is the SLED AI 2K. That's an easy one. To follow these patients, there appeared to be this long-term, and again, long-term being 15 months. So that's a topic of discussion when I'm done, but drug-free remission during this time. They also followed other measures beyond the clinical measures, looking at serum C3, as well as double-stranded DNA antibodies, which you can see here on the right side of the slide. So where are we with autoimmune disease? Right now, there are many different CAR-T clinical trials that are either just enrolling or getting ready to be activated for multiple sclerosis, myasthenia gravis, and one in stiff person syndrome, as you can see here on the slide. I also provide the link. These are all available for review at clinicaltrials.gov. So what does this look like for a patient? Well, I'll tell you, CAR-T is complicated. These studies require a tremendous amount of multidisciplinary care and coordination, lots of specialties involved, as well as the laboratory when it comes to processing the cells. I'm going to walk through here what the patient journey looks like for CAR-T, because, when patients come up and ask about these clinical trials coming up, it's really hard to know all the steps that go into place. And I think it's very, very important for patients to realize this is a very intense type of trial. So starting off, after consent, after screening, the process really starts with apheresis, or collection of the blood, collection of those T cells. Those T cells, or the blood, you'll basically isolate those T cells in the lab, and then those T cells undergo this genetic modification to get that CAR protein on the outside, again, using a viral vector to do so. It takes time, depending on the protocol, around, we're talking 40-ish days to genetically modify these T cells and then grow these T cells in the lab. Oops. Once the T cells are ready, patients will be prepared to receive their cells back. First, they get lymphodepletion, and lymphodepletion typically happens over a series of a few days, approximately 3 days. Then they get a little bit of a break, a day or two, and then they're ready to receive their T cells back. Oops, we're going the wrong way here. Once patients get that T cell infusion, that happens in the hospital. And most protocols, you're looking at a 10-day stay in the hospital. So again, this is something that is very intense for patients. When those patients receive their T cells back, the whole concept is, like I showed earlier, that these CAR T cells hone in on their target, which is those CD19 B cells, and destroy them. I didn't know if there was a question. At the end of this process, once those B cells are destroyed, the theory is the unhealthy ones are gone, and then a patient can replenish their hopefully healthy B cells, getting rid of the underlying process that is driving the autoimmune disease. So what is the advantage of CAR T over our standard monoclonal antibodies, for example, rituximab, just using a common one that's often used? Well, the thought is that is really twofold. Here on this slide, I'm going to show that you can see that depth of B cell depletion much more with anti-CD19 CAR T. So on the left hand of the slide here, on the top row, this is a lymph node from a patient that basically showed their CD19 and CD20 highlighted here in brown with the stain. After CAR T on row 2, you can see pretty much those CD19 B cells completely depleted in the lymph node. Now, if you look at that in contrast to the third row here, after just rituximab alone, you still have a decent amount of brown staining, again, still having some B cells retained in that lymph node. So the depth of penetration and depletion of those B cells is greater in those lymphoid tissues. Additionally, we know drugs like monoclonal antibodies, rituximab, ofatuzumab, ocrelizumab, are big, bulky monoclonal antibodies. They don't really cross that blood-brain barrier, whereas, CD19, 20 B cells do, and you can get these resident B cell follicles within the brain tissue or the central nervous system. And in theory, with CAR T, that does have the potential to cross over and get deep tissue penetration even within the CNS. I'm going to move now to and pivot to a different type. Oh, does someone have a question?
I might just ask a quick one. Sometimes a critique might be strong, but the impact that the lymphodepletion has on sort of the immune process. I mean, do you think that, like, for example, if we did lymphodepletion and then did Rituxan, would you get a similar-ish benefit, do you think?
I don't think so. And the reason being is, and I'm going to be a little biased because I know the protocols that I'm heavily involved in. So I think it depends a little bit of how much Cytoxan, for example, you're using, but the protocols that we're using for stiff person is a fraction of what I will use even clinically to treat autoimmune disease. So, 300 milligrams versus, we use 750 milligrams per meter squared for autoimmune disease. So I don't think that's the whole picture. But worth a discussion afterwards, because certainly that is going to be immune suppressing. It is only short-lived, so the protocol that we're using for SPS is 3 days. I don't know if that's enough to have a sustained response. All right, I'm going to move on to CAR with the extra A. This is a novel approach being explored for targeting disease-specific B cells while leaving those healthy B cells intact. What does this look like? Here's an example of how this could theoretically be utilized in autoimmune encephalitis, specifically NMDA receptor encephalitis. This is a great example because we have a antibody driven disease where these are pathogenic antibodies, NMDA receptor antibodies are being produced by specific B cells. So with this current treatment paradigm, what we basically do is wipe out that part of the immune system non-selectively. We use things like steroids, IVIG, maybe a little more selective with rituximab, but still just wiping out all those B cells in hopes to suppress that antibody production. Even what I just talked about before, CAR with the 1A, this is a non-selective approach of those CD19 cells. This is in contrast to, this is in contrast to CAR-T with 2As, that is a precision type of immune therapy. So in this setting, we are using not only a B cell target, but also a target against the NMDA specific B cell. So you can be very selective in your B cell depletion. This is another slide here I borrowed from Dr. Monsum Reich that he was okay with me sharing, but this is again another way of looking at that NMDA specific CAR-T. And there's a great paper again with Monsum and colleagues looking at this, developing that type of targeted approach for NMDA. I'm going to pivot now and talk about the current clinical trial in stiff person syndrome that is newly activated. This is KYSA 8. I'm sure many here are aware of what stiff person syndrome is, but just a quick recap. Again, I could have a whole hour lecture on this, but stiff person syndrome is a rare progressive autoimmune neurologic disease, often associated with GAD65 antibodies, less commonly, but the second most common antibody, glycine, among other rare antibodies such as amphotericin. Stiff person syndrome has a bit of a spectrum. It is a difficult diagnosis. It can range from stiff limb syndrome to your more classic SPS, all the way to an extreme example of PERM or progressive encephalomyelitis with rigidity and myoclonus. There are no FDA-approved therapies for this disease. IVIG is often considered first line. There is a positive control trial that of a small prospective study that showed benefit. Unfortunately, after about 3 years, we see a third of patients having this wearing off and continue to progress despite IVIG. There was also a randomized controlled trial which was negative in rituximab, although anecdotally and based on small cases as well as selected patients in this trial, there does seem to be a benefit in the rights population, although we don't know what that rights population truly is. This concept of using CAR-T therapy, specifically KYV-101 was the CAR that was used in stiff person syndrome, started with a clinical case in Germany. There is a program with compassionate use that this was basically used for a patient with severely refractive disease. She had long-standing SPS, initially treated with immune therapy, which she stabilized for a short period of time over 3 years, and then 9 years later had significant worsening to the point where she was bedbound. You can see on this complicated timeline here, she went through many different therapies, had a prolonged course of her SPS, but did receive CAR-T later in her course, again, confounded by a lot of other immune therapies, as you can see here, but did receive CAR-T and went from bedbound to ambulating without significant difficulty, but still using her walker. So this was a proof of concept that had really helped launch this phase 2 trial. This paper also shows the aspects that improved in this particular patient. There was improvement in her walking and uninterrupted walking, so still walking with a walker, but able to go at a faster speed, longer distances, which are outlined here in these graphs. There was improvement in stiffness, pain, as well as the need for diazepam. So highlighted here, at least in the two graphs, there was the modified Ashworth scale. So just to shout out or to call out, this was not a stiffness index, which is the preferred scale of stiffness in stiff person syndrome that is being utilized in the clinical trial. But even just using the modified Ashworth, there was some improvement in tone. The other thing that is graphed out here is the reduction of diazepam, which was reduced by 40% after 5 months of CAR T, and not grafted out is just demonstrating that pain had significantly improved over this time. So where we are today is that there is a phase 2 trial using KYV-101, this CAR T, the same CAR T construct for refractory stiff persons. So one must be refractory to IVIG and still have, a significant amount of disability. There are 3 participating sites as of now, which are on the slides here. We're actively recruiting in Colorado as well as Jefferson, and Mayo will be joining shortly. This is an open label study. It is 25 patients total. The primary endpoint is a change in 25-foot walk, as well as safety, of course. But the concept of improving with walking was shown in that case report. So this is hopefully a good functional outcome where we can improve upon with patients. There's many other secondary endpoints that are listed on this slide, and the timeline here, which I already outlined of what this looks like for a patient, is just summarized below. So what about this molecule is exciting for autoimmune disease? Funny enough, anti-CD19 is used for lymphoma, particularly Yescarta, which is listed here on this slide, that has FDA approval for lymphoma. There is a lot of neurotoxicity, a lot of CRS we can see with this, but this particular construct was modified in the hinge region to hopefully decrease that cytokine release syndrome and neurotoxicity. This has been used in at least 50 patients by now, if not more, but summarized here on the slide is 20 patients with a lymphoma and 30 patients with autoimmune disease. So we're going to come up next on an open discussion and Q&A, but before we jump into that, I just want to give a shout out to the Autoimmune Encephalitis Alliance. Thank you for giving me this opportunity to speak today. I just want to say this organization has been wonderful for my patients in terms of outreach, patient education, and as we know, hopefully today everyone feels the same way, physician education. This is coming up on Gibbs Day. Sorry, we're way beyond Colorado here, but just Giving Tuesday. We call it Colorado Gibbs Day in our state, but Giving Tuesday. So I just wanted to throw that out there. But thank you.